Welcome, everyone. I'm Michael McNutt with WEDI, and welcome to our virtual spotlight, Improving Prior Authorization Processes and the CMS Proposed Rule, Insights for Preparing Successful Implementations, presented by MCG. Please welcome today's speakers, Raj Godavarthi and Daniel Kaywood with MCG. Raj is MCG's Associate Vice President of Technology and Interoperability and a WEDI board member, and Daniel is MCG's Product Manager of Interoperability Solutions. Gentlemen, welcome.
Thanks, Michael. So let me share my screen here. Okay, good morning, good afternoon, everyone. Thank you for giving your precious time to be with us and go through this prior authorization improvements presentation that MCG has been doing over the last couple of years. Thank you for the opportunity, the WEDI team as well. Today, Danny and I will present together the new CMS proposal rule that came in December. What are some of the key insights and the capabilities they're highlighting in the rule? And also we talked about what does it mean to payers and providers based on our experience implementing this automation with at least 2 payers and 3 providers so far. And we have gained a good amount of experience doing this. And also Danny will share towards then some of the metrics, how we measured some other things. So with that, let's get into the CMS prior auth rule that is proposed in December. And when you look at the proposed rule at the very high level, the big picture, it's important to understand what they're trying to accomplish in the rule. When they issued the rule, they have shared some of the statistics, as you see in the bottom grid here. They mentioned about how much the burden the prior authorization processes are on the physicians, on the nurses, and the clerical, and per hour and per year, and the totals. So if you look at the rule, there are a bunch of stats like this, and it really amazes that how much time the physicians and the provider offices are spending. At the same time, even the payers on the other side, spending a lot of time on the administration side to process these auth requests. So overall, the burden is heavy, and we have several stats from AMA surveys and these CMS rule as well. The goal for the CMS proposal is to improve the health information exchange. So what they're trying to accomplish is that to reduce the burden on the patient and the provider side, and to improve these processes, they're trying to enable the information to flow between payers and provider systems seamlessly, and then hence reduce a lot of that burden. So that is at the very high level what they're trying to accomplish. So we will go into the details. By issuing this rule, they have withdrawn the previous rule that was in place, and it was frozen back in the previous government and previous administration. So because the previous rule did not include the Medicare Advantage, and the previous rule did not give the time for people to comment. So this proposed rule that CMS issued in 2022 December includes the plans to withdraw the previous rule. So with that, we will focus on the present rule as much as possible today. The proposed rule impacts the payers who supports Medicare Advantage and state Medicaid and CHIP agencies, and the Medicaid and CHIP managed care plans and QHPs and others as well. Also the impacted providers you see here. So this is what the new proposed rule says. These are the impacted payers and providers. They need to pay attention to the details of this rule. And then when you look at this rule, I think the goal is, as you see, almost at every level, the improved patient outcomes is one of their main goal. So in the prior authorization process, we do have the patient access API through the Cures Act and number of things we should expose to the patient to access from their apps and wherever they are. They're including this prior auth status part of that bucket. That part of this process that we should, the payer should enable the patients to access the prior auth status no later than 1 business day after payer receives the auth request. or the status change. So this is the new addition to enable the patients to access the auth status. In the same manner, on the right side, you can see the payers must report these annual metrics about the patients accessing this information. So this is bringing the prior auth closer to the patient, so that patients are also informed about what is my authorization status. A lot of times patients spend a lot of time calling the physician's office or waiting upon that information. And this rule is enabling the patients to access information through the MyChart or through the apps they have access to. And then going into the prior authorization improvements, the CMS proposed this new terminology called PARDD, prior authorization requirements, decision, and documentation and decision. They call PARD. So it's probably you could confuse with PARD, but this is pretty close to that. But the intention is that the prior authorization has three specific, pillars when it comes to the different things that happens under that umbrella. And we'll talk them through in detail. So what they're saying is these three buckets of automation process, these three buckets of processes, they would like to automate eventually using technology. So when you look at their goal, they wanted to streamline the prior authorization process by automating certain tasks. So if you're paying attention to this webinar or reading that rule, you must look at what happens under these three buckets, either on provider side, on the payer side, or through the vendors that they use, and what are the different steps from the point of intake to the decision. What are the things that the CMS is looking in terms of automating? So we are going to go through them in detail as well. But the real goal, as I said in the first slide, to exchange this information between providers and payers, and then hence use the technology to automate several of these tasks, so you reduce the burden on both provider side and the payer side. So that's what their goal, using these three different buckets of technology things. So going to the next slide here. We tried to put in this a picture so that you understand what exactly the CMS is proposing here. So they are proposing that improve the prior authorization processes by automating. So if you look at each bucket here, they say that in the intake process you have today, that whether it is coming from fax, portal, or EMR, can you make a determination based on the intake? Does it require prior auth? Can you automate some of these steps here on the payer side, so that if you can respond, it doesn't require prior auth. And often our payers say that they get 40–50% of the authorization requests through the portal and fax. It doesn't require any prior auth. So that is the first thing they're trying to handle here, right? Can you respond to the intake quickly? And then if it requires prior auth, then you must identify what are the documentation requirements are, and then you must respond with some machine readable documentation requirements. That means you are not just sending a link to your website or a PDF, but you are sending a documentation requirements in a way a machine can read on the EMR side and present to the provider with answers. So this is where there is a big lift for the payers, like looking at their own policies or whatever they're using today. You must construct them in a way they're machine readable and present to the providers within the EMR. Then the third bucket they're looking at is clinical documentation. Once you provide these documentation requirements to the provider, and then you get the documentation with all the answers, can you structure that information on the payer side in a way you can automate a determination, right? So you may have several manual processes here, but what can you automate between the time you receive the documentation to decision? So that is the other part they're looking at. And finally, once you make the determination, and then how do you notify, right? We have seen that they would like to give this to patients and communicate to the providers real time without having them to call or go to the portal. So these are the four buckets of work they're looking through this rule to automate as many as possible. So we'll go through each one of them slowly. So the first one they are looking at here is the prior authorization requirement step, right? As I was talking about the intake to decision. So when you consider implementing this on the payer side, you may have different intake channels, right? Things are coming from different places. Some of them you delegate, some of them you handle, some of them you have your own internal processes. But their goal is that you determine, as soon as the intake comes, it requires prior auth using, technology. We use the word API. It is nothing but a technology terminology to say that can a provider get an answer in real time from the payer, whether this requires prior auth or not. So this provider probably doing this, placing an order or scheduling a PT or doing a referral. So wherever they are in the workflow, they should be able to query a payer and say, I'm trying to do this, does it require prior auth? So a system-to-system communication between provider to payer and get an immediate answer, yeah, it doesn't require prior auth, please continue with your workflow. So that is the first thing they wanted to accomplish by asking the payers to provide this kind of capability. And when you look at this whole CMS proposed rule, they have focused on capabilities more than talking in too much of technology jargon, like the previous rule was. So that is the first capability, respond to the provider in real time. Then the second capability that they were looking at, the prior authorization documentation process. So once you say that, yes, it does require additional documentation, then you need to identify those documentation requirements, and then you need to codify them. So let's focus on, identifying the documentation requirements. So you may be using a lot of your own policies, or your, the state regulated policies, or your customized own policies, or you're using MCG guidelines or somebody else guidelines. It doesn't matter. What they're saying is that you should have a technical capability on the payer side, so that when you're getting an intake request for particular service or particular, DME request or whatever it is, you should be identifying, in real time for this particular service request, what are the documentation requirements, and then surface them within the EMR workflow, right? So there is a whole technology framework underneath that. But what it means for the payers, they should have an automated capabilities to identify, all these mappings. For this service request, for these kind of parameters, I wanted to surface these kind of documentation requirements. So all that stuff that the payers need to organize, so that providers will get in real time those documentation requirements in real time workflows within the EMR. And it essentially removes that guesswork, like, what kind of requirements payer has, that's one of the burden we see. And having this real-time response that providers can access within the EMR, greatly reduces that burden. Then the next one, in the same, documentation, what they're saying is that, you need to present the information in a machine-readable format. So what does this mean? Right, when you have a set of documentation requirements, those requirements could come as a question. What is the patient's oxygen saturation rate, or what is the patient's creatinine in the last week or last month? You're asking all these clinical questions, and a lot of these clinical questions has a need for a person to review the chart and then answer these questions. But what CMS is proposing here is that if you codify, or if you make your documentation requirements machine readable, that means that when you present that question can interact with the clinical data that is already there in the EMR, and then present those recommendations to the reviewers on the provider side. They don't need to review the chart, right? So these machine readable documentation requirements are very powerful, because they can interact with the terminologies like SNOMED and ICDs and all that, so that it can interpret that question based on the data that is available and see if there are answers for those questions. So what they're trying to do is that they're trying to automate the process of documentation on the provider side to reduce that burden. Otherwise, providers need to hire a bunch of back-end staff to answer these questions and to submit these documentation requirements. So CMS is asking, comments from all the payers and anybody who's interested to say, what does it take to codify your guidelines or your documentation requirements? This is a huge lift for the organization. Companies like MCG, we spend a lot of time and investment codifying, our requirements so that they're accessible to the providers real time. And the third bucket is the prior authorization decision process, right? They're trying to, improve this process as well. So what they're saying is that the payers must provide a technical capability so that when they receive this information from the provider with all the clinical documentation requirements, they should be in a position to determine the status of that service request and then share with payers and providers real time. Share with payers and providers real time. That real time is important. You may have a process today to say that I'm going to automatically pen this particular service request based on where it is coming from, based on what they're asking. That is okay. You penned it. As long as you can, enable that information to communicate to the patient providers. That means payers should have a technical capability to say, for this authorization request, you can access the status using this API or using this technology. So this helps the patients and providers to real-time access the status without going to the portals or calling the payers, right? This eliminates a lot of the burden as well. So that is another thing this proposed rule is focusing on. Together, between these three buckets of work, prior authorization, requirements, documentation, decision, they're making a fundamental shift in this proposed rule, which is, we are going to commit to HL7 FHIR standards, which is the future. But if you look at the rule, they focused on capabilities rather than focusing on, which implementation guides, which version that you should use. They recommended certain things from HL7 Da Vinci standards, but they did not force any particular version and leaving that to the implementers. But they focused on these capabilities must support technology standards like APIs and FHIR standards, so that when you implement across many payers and providers, it scales. They suggest that you don't create a one-off integration for each payer and provider because it doesn't scale. As I mentioned, that they stayed away from specifying the implementation specifics using any particular implementation guides in the industry. And then automation of tasks for the providers workflow is emphasized throughout the process. The things that providers are doing today, what can we do to automate and hence reduce that burden? And it doesn't apply to the drugs. That is also clearly mentioned in the rule. So this is the last slide from my side, and Danny will go in details from our implementation experience, what we have done. I think I have a couple of more slides. But if you are a technology or if you're a clinical person on the payer side, what does it mean to implement that, right? So you have three buckets of work you have to do. And you have to see where you are today and what does it take to change all of them. And we have done 2 implementations so far and working on the third one. And it's a huge lift for the payers. And it's not easy. And it's going to take time. It's going to take a lot of money and effort. So on the prior authorization requirement side, you should think about implementing a technology solution that should answer a question real time under 5 seconds. Right? That's what we have targeted for. Because when provider is submitting an order or when provider is creating an appointment on the schedule, these things are talking behind the scenes between system to system. And if you provide that technology on the payer side, the payer should respond as soon as the request comes from the provider that either it is delegated or it doesn't require prior auth, all that information. During this process, on the payer side, when the request comes, you should have the technology to do the eligibility, to check the benefits, to see the provider, in network or out network or other provider engagement requirements you have, and what kind of procedure diagnosis they're asking. All these things you have to accomplish in real time. And it seems a monumental task, but these are the things that you need to do in order to answer this question sometimes. And the second bucket, I have a detailed slides. Let me go through that. The second bucket is the documentation, right? So when you think about documentation, as I mentioned, there are technologies to do that. We have used to codify this and to scale it for multiple providers. Even different EMRs use the FHIR standards, and we used CQL, where we take a guideline, we convert into this CQL structure, which generates the FHIR queries and all that. So when you think about implementing a technology solution to surface the documentation requirements to the providers, you have to do a lot of plumbing underneath on the payer side to create these machine readable guidelines. And finally, on the decision side, as I mentioned before, that not only that you should create a technology compliant, that you also need to think about if you don't have exception to use FHIR, you have to convert them into X12 every time. Every time payer communicating to the provider or provider sending it to the payer, they have to use the HIPAA compliant transactions. But if you have CMS exception, if you're a HL7 DaVinci member, you can get an exception, then use FHIR for 3 years. And then you must capture all those metrics on the back end of the payer side so that annually you can report that. So with that, let me hand off to Danny to go through the implementation side.
Thanks, Raj. So from an implementation side, one of the things that we've noticed is that the clinical use case that you are trying to implement. So for authorizations, there's lots of different types of authorizations for different settings of care. And one of the things that we've noticed is the actual clinical use case and the setting of care for which you're trying to implement this can make different parts of this a little bit more difficult. So like Raj mentioned, we've done this with 2 payers. We've done this with emergent inpatient admissions, where a patient might, present to the emergency department complaining of shortness of breath, and a doctor wants to admit them to inpatient care. There's another, the other use case we've done is elective surgeries, elective procedures. And so when we think about these 3 different buckets, the requirement side, this is a bit more difficult for those elective procedures. Think about, is an authorization required for an emergent inpatient admission? The answer is almost always yes. So and obviously not always yes, almost always yes. There are definitely carve-outs in certain situations where that is not true, but for prior authorizations, there's a lot of different types of things like provider gold carding. There is certain benefit plan carve-outs for certain commercial plans where authorization is or is not required for certain services. So it's a little bit more complex when you're talking about services that are going to be performed in the future. From a documentation perspective, these different use cases are reliant on different types of data. You think about inpatient admission criteria is a little bit more reliant on discrete data. So, your pulse oxygenation levels, your breathing rate, some of your vital signs are a little bit more present in terms of inpatient admission criteria than they are on the elective procedure side, where an example of one of those might be presence of significant radiographic findings if you're talking about something like a total knee or a total hip. And so that is going to be a lot from indiscrete data. You're going to get a lot of that from physician notes. So that's another sort of difference between these 2 different clinical use cases. If you think about other use cases as well, maybe home health for Medicare fee for service, you're looking a lot at different types of documentation requirements. And so that is what we are looking at from a documentation perspective. And then on the decision side, this is where the transactional aspect of this comes in. So Raj talked a little bit about sending that decision back, but it's rarely just a decision, right? It's rarely just, is this approved or is this denied? There is, on an inpatient admission, you're looking at a number of days that are getting approved in a per diem sort of situation. There's a number of days, there's a next review date. So the patient comes in on Monday, they get 2 days approved. Wednesday comes around, maybe they're not ready to go yet. And so now there's a subsequent authorization that becomes a child of the original. So that's different. On the prior authorization side, elective procedures, there can be multiple different codes on a request. If approval is given, it's given for a specific date span. Some things on the request can be approved, some can be denied. And so there's partial approvals, different things. So when you're looking at these different, when you're thinking about implementing this, get very into the details on the clinical use case that you are trying to implement, and make sure that from requirements to documentation to decision, everything is set up. Everything is set up to work together. It's hard to do this and just take every single clinical use case all at once and let's go. From MCG's perspective, it's much more valuable to start with something and then start to build from there in terms of bringing in more services. Raj, can you go to the next slide? So from a provider implementation perspective, on the provider side, that we've had some insights and we've noticed some pain points. So getting a reliable patient provider and order context is challenging, depending on what EHR you're trying to implement this with. And making sure that the right patient, the right order, and thinking about things like patient merges. Those are proving to be challenging when we're trying to get this from the Smart on Fire launch context, which is what those Da Vinci implementation guys Raj was talking about would require. So patient merges, provider data is, I'll talk about that a little bit on the payer side implementation as well, but who is this provider? What is their payer specific provider ID? A lot of that is not in the EHR. And so we're having to search for that given other data points like first name, last name, NPI, and a few other things, address. Coverage requirements discovery in general, that requirements piece is painful. That includes provider search. It includes benefit and eligibility checks. It's not easy. And certainly some of the things that the Da Vinci work group would call out of those implementation guides that are referenced in the CMS proposed rule. Some of those technology pieces are not in place yet with the EHRs. And so finding workarounds to that can also be a little bit painful. Tell me what is missing very early in the documentation process. So providers want to know, are they going to need to go somewhere else to get something that's going to be needed for this process as early as possible. And then automating some of these tasks, tracking decision metrics, obviously, but automating as many of these tasks, eligibility checks, provider search. Can we do some of this work before providers even start filling in data? That has been one of the provider side insights that we've had on the return on investment side. Looking at the provider side, I'll talk a little bit more about metrics here later, but qualifiably, excuse me, we've had some providers talk about, we've never had our fax buckets coming back from the payers be empty. Our decision fax queues have never been empty, or our request for additional information or denials, all of those different decisions that come from payers. This rule, if implemented as proposed, would have payers sending real-time data right back to the EHR. We've done this, and this has been providers' biggest, the biggest thing they mention when they're talking about this is getting that decision back. We have MCG as provider customers who say we have one FTE solely dedicated to seeking out authorization statuses from one payer that we work with. So getting the authorization status back into the EHR where it belongs in real time and not having to have a human work on that on the provider side has been very valuable to them. Raj, you go to the next one. Let's talk a little bit about payers. HL7 Fire Standards implementation is a technical and a business lift. So when you're thinking about implementing Fire, it's not just the engineers, your software engineers, changing over some of your database and API structures to this. There are certain values that you might be using as a payer related to line of business, related to certain other things, benefit plan names. Some of those values may not exist the way you think they're going to exist in the Fire implementation standard. So it's not just your software engineers going in and mapping value to value. Sometimes you might need to change some of the values that you are using to match the value sets that exist in the standards. A real-time API that can handle multiple requests. So this is also this bottom bullet here, like legacy system integration. So you think about all the different questions that you have to answer to even say, is an authorization required? So is this member eligible for benefits? Is the service that's been ordered a covered benefit under that member's plan? Is the provider who's going to be servicing this request, are they in network? Is that provider gold carded? Is that provider on some other sort of a list that would require them always to require authorization? All those different questions need to be answered inside of that is auth required question. And for the most part at payer systems that we've seen, those are all different systems that are going to answer those. So reaching out to those different systems, getting real-time answers, coming back, that is part of this, and making sure that technical orchestration is working and handling those steps in the right order. A dynamic rules engine that can use both clinical and business data points is part of this. And then again, tracking decision metrics and tracking metrics overall. As you go down this compliance path, MCG does believe that both payers and providers are going to see this is going to feel more like an investment for a return than it will be a cost that we have to incur to implement this. We believe this will save both payers and providers a pretty significant amount of money. But in order to prove that, we have to track before and after on some of these different processes. Raj, if you go to the next slide. We're thinking about organizational readiness from a clinical perspective on both. I'll talk a little bit about payer, a little bit about provider on this. So maintaining a list of services that doesn't require prior authorization, that is configurable and accessible by other systems and electronic systems as well. Mapping and maintaining documentation requirements to codes. Codification of policies. Raj talked a little bit about this when we're talking about if there's a criterion that says, tachycardia is defined as a patient that has a certain heart rate over a certain threshold for their age. It's taking that human readable information, making it into rules that machines can read. And like Raj said, that does require significant investment if this rule were to be finalized as proposed. Automation of determinations, so leveraging some of that structured data, and then consistent denial reasons. So from a payer perspective, this would mean using, again, a set of standard values. CMS is calling out in the proposal the X12278 list of values. This might be another scenario where your internal values are not going to match one-to-one with the standards. And so deciding what that means from a business perspective for your organization before you implement it technologically is part of this. On the provider side, these consistent denial reasons, one of the things that we've seen is this will allow you, once you start getting these structured denial reasons, allow you to start automatically putting them in other work queues. Maybe you have on the provider side a team that does appeals. Maybe you have some reconsideration processes with a few of your different payers that allow you to reach back out. Maybe it's scheduling peer-to-peers. So any of those things, starting to get these structured denial reasons will allow you to start setting up on the provider side, automatically sticking this in different teams' workflows to help you move forward there. From a technical perspective, ability to distinguish between different authorization requests. So has your organization delegated this to whom, and are there any exceptions to that? We've worked with a few health plans who have a lot of different rules around this. They delegate certain requests unless the turnaround time has to be within a certain time frame, unless it's marked as urgent, then their internal teams do it. So what are those rules on the delegated side? Development of APIs for external consumption and making them scalable. Mapping. So one of the things in this rule, it demands the use of FHIR, except for where HIPAA requires X12 to be used, and that is on that actual create case, and transmitting between payer and provider requires X12 to 278. This mapping between FHIR and X12 can get ugly if you are not closely mapping some of the values and deciding which values won't be accepted based off of your ability to map. HL7 knowledge and training, system availability, robust logging. And again, we believe that this will feel more like an investment than it will a cost to implement. And to prove that, tracking some of those different metrics. And then operational, maintaining 2 systems for a period of time. CMS in this proposal has asked for industry feedback on doing a phased implementation approach for this. We, in general, from an MCG perspective, encourage anyone who has questions, wants clarifications, or wants to submit comments on this to submit comments on this. CMS has requested comments, and we have certainly talked to some of our customers on the payer and provider side about submitting comments for this. Having additional training and job guides, having staffing to support the transition, supporting turnaround times. They have, CMS has also suggested in this rule different turnaround times that would apply at a national level. Something else to investigate for your organization if you think that would be impactful for your operations. And then measuring your operational efficiency. So how many manual tasks are you doing today? How long are those manual tasks taking? And then what are the frequencies? So what types of authorizations are requiring those manual tasks? Again, there might be certain things. You might be getting a lot of elective procedures coming in through your portal as a payer, and maybe hardly any of your inpatient admissions or home care requests. So those different pieces, and then decrease in denials or a decrease in appeals, looking at from a health plan perspective, appeal success rate, those types of things CMS is requiring as part of this rule, if it were again finalized as proposed, that some of those metrics get reported out publicly, and seeing your impact as an organization on those. From at the very end here, before we open it up for questions, I've seen there's a few different chats going back and forth. On the provider workflow, this is different depending on what sort of clinical use case you are looking at, whether it's an elective procedure, whether you're looking at an inpatient admission, or any other type of clinical use case. But steps that providers complete during their workflow, so eligibility verification, determining is an authorization required, documenting those payer clinical requirements, sending that review over to the payer, and then getting that authorization status. We're using MCG proprietary data here for use cases, and then we're using CMS's hourly rates for these folks that are included in the rule. That's what we're looking at here from providers, looking at spending, depending on, again, the use case and what have you, $65 per authorization. That is a very high number, and you'll see when Raj flips over to the next slide, the payer number is very similar. They're doing different tasks, yet also some of these tasks are the same. So case intake or triage, reviewing that clinical data. Again, payers are often reviewing the same clinical data that providers are reviewing to determine medical necessity. What if they could review together? And that's kind of one of the things that this rule, if finalized as proposed, would help with, in terms of the provider does their clinical review, payer gets to see the provider's clinical review and all the data they need to do their own. Requesting additional data, medical director review. Obviously, this isn't in all cases, but when it does happen, it does take a significant amount of time. Notifying the provider of a decision, and then getting that communication back over. And in this receiving and documenting communication is both sending it back to the provider, and then if it wasn't a approval or a denial, but it was, we need more information, it's getting that information back and putting it in the system. So these are some of the metrics we've collected, and the as is today, what we're looking at. As we move forward, we're hoping to see these start to decrease, and CMS has some information about that in the proposed rule as well, some of the assumptions they've made about what types of these tasks can be automated. When we look at to wrap up here on the last slide, and we'll open up for questions. When we look at the automation vision for this overall space, and looking at what the CMS rule, taking a step back from the proposed rule overall and just looking at automation, prior authorization automation, what does that mean? So at level 0, and generally on the left-hand side of this, you'll see automation opportunities are administrative. We look at this as a journey, not as a destination. So you're probably never going to get to automation, quote unquote, whatever that means. But you can make progress looking at a scale like this. So level 0, this is everything being fully manual with phone and fax on both the payer and on the provider side. When we talk about level 1, that's where we start to talk about payer portals. So when payers issued provider portals, some payers have, some not, but this providers entering that information into a portal automates part of that payer admin from an intake activities perspective. It also automates some of that looking and hunting for decisions from providers. Providers get to get their decisions a bit quicker and with less time per authorization when they're able to see it in a portal like this. Level 2, you're taking a few other steps. So this is where CMS, this is where the CMS proposed rule starts, right? So level 2 is EHR-based workflow, asking payers to be able to accept and respond to authorization requests from the provider's EHR. This automates some of the payer admin, automates a lot of the provider admin. We talked about those decisions coming back and forth from payers in real time into their EHR, greatly helps ease the provider workflow in this world. Level 3 is also part of what CMS has talked about in this rule when they're talking about the documentation part of the PARDD API that Raj talked about a little bit earlier. So this is allowing providers to see the payer's documentation requirements and attest to certain things in there. Payers could auto-approve certain requests based off of that criteria being met based off of attestation or not, up to them. But that is, that's level 3 here. Level 4 is where we actually, this is the last piece when Raj was talking a little bit about codification and making your criteria machine readable and quantifiable. This is where you can take some of those things like I talked about with vital signs and having certain thresholds for vital signs to prove certain different clinical criteria. That's what this level 4 is. And then level 5 is what everybody wants to talk about. This is the, when you talk about utilization management, prior authorization, automation overall, when you're not talking about the CMS rule or when you are, everybody wants to talk about artificial intelligence. Is artificial intelligence ready to be the silver bullet that's going to solve all of this? From MCG's perspective, probably not, but it can help with certain things. So when you're thinking about hunting through doctor's notes, looking for the different phrases like looking for significant radiographic findings, is there an ability to say, here's the type of significant radiographic findings we're looking for, and use something like natural language processing to hunt through those notes and find those different data criteria, pull them out and put them in a clinician's hands to say, here's where we found this and here's what it looks like? Yes, we believe that you can use artificial intelligence to make people faster, and we've seen that succeed on the MCG side. I'm going to stop talking now.
So one last
Raj will do one more here.
Yeah, then meanwhile, if you can read the questions, we'll get to them. So couple of minutes on this slide, and then we'll go to the Q&A. When MCG has been, thinking about how do you put a foundation for this automation, we came up with this particular 5-level, slide deck to explain these things, because it's a very complex process when you try to intersect both clinical workflows with the technology and everything we talk about. So when CMS proposed, we're going to simplify this into 3 buckets, what are the requirements, what is the documentation, and what is the decision. But for all these things to happen, when you're considering a solution on the payer side, you should look at number of things. Otherwise, you're going to have a number of vendors solving 5 different problems, and you'll go back to managing all those things. So you have to look at what works best for you, because you probably have already systems in place internally. So the baseline is you need to have medical necessity guidelines or what are the policies that you use that tells that these are the documentation requirements for certain things. So certainly from MCG point of view, when we looked at this whole automation, that is our bread and butter. That's what we do here. And then the second layer we built is that we codified those things. We created a machine readable, guidelines or rules for these documentation requirements, so that when a guideline interacts with the data, a clinical data that is coming from EMR, which is structured, we can automate a lot of questions and answers. And that's where we have invested quite a bit. And we have, some machine learning models around that for unstructured notes as well. And the third layer is, once you have, the documentation and along with the clinical data that is coming to you, you should be in a position to automate a lot of questions and answers and present it to the reviewers. What everybody wants is that don't show me anything, just answer the question whether it is approved or not. But I think, we have to earn that over the process. We are very early implementing these things. So what we believe is we auto assist in the documentation more than auto document, right? We pre-populate the answers for questions based on the codification, based on the technology we have implemented, but we still surface them to the reviewers and say, do you agree with these things? Because you learn over a period of time, these questions are right based on, some of the metrics we gather, and they're confident confirming it, and then we automate those things in the future. But at the phase where we are in the early implementations, we auto assist and provide that to the reviewers. And then you have this rules engine as a fourth layer, right? You should be in a position on the payer side, once you have an intake coming in, or you have a clinical decision for the medical necessity to say, it met all the indications of your policy, you should be in a position to configure them and run the rules so that, you're automating that step instead of having a manual reviewer clicking the button and sharing that information to others. So these rules engines provide a greater flexibility to configure based on course providers and length of stay or a number of clinical data metrics. You can automate that process and communicate to your internal systems and external systems as well. And finally, supporting the standards, right? We can't get away from not supporting X12 and FHIR standards. So you need to have a layer where we say, if payer is using custom API today, and we believe that, we have to meet where payers are. We cannot ask payers to go and change all your stuff. It's going to take 5 to 7 years. So we believe you provide a data exchange layer where we say, if payer has a custom API, we take that and convert into, FHIR or X12, whatever it is. So you need to have that kind of flexibility so that you're not asking payers to, change everything and it's not, feasible for them. So you need to consider all these layers when you're considering an automation foundation and solution for your payer. Otherwise, there may be a fragmented set of solutions that you're implementing and maintaining in the long term. So with that, let me come out of.
Yeah. So one of the questions that I wanted to answer first. So Glenn and Benji had an exchange in the chat about Glenn asked, are payers taking a big bang approach to this implementation or focusing on a specific service line to start, e.g. high volume, low complexity? So from MCG's experience, so as we go into this Q&A, I want to reiterate again, we work for MCG. We do not speak on behalf of CMS. We're here to give you our opinions based off of our knowledge of implementing some of these solutions. We can't answer anything about what does CMS mean or what is CMS going to do. We can only give you what we know in terms of implementing this. So from MCG's perspective, payers are not taking a big bang approach to this implementation. And we are recommending our customers focus on specific service lines to start. And high volume, low complexity is one of the things to consider. Volume in general is something to consider. Another thing is providers. So don't try to implement this with every single provider at the same time. Find a provider who wants to work with you, who you're comfortable working with to work through some of the inevitable issues that are going to come up while you try to implement something like this. What services are those providers submitting to you at a high volume? That's really the question to answer. So in the CMS rule as well, they have asked for industry comments on, is there a way to do a phased-in approach for this? MCG recommends everybody take a thought about that and comment on that particular comment on that particular item in a way that makes sense for your organization. Benji, your answer, finding the top 10 scenarios is one way to go. One of the things that CMS has called out in their rule, and something we've noticed, is every payer's top 10 is different. And so when you think about a provider who works with 30 payers, if they're doing 2 different processes for this submission, for the same code or for the same, for the same type of service, just because it's in one payer's top 10 and not another, that's something to consider too when you think through these phased approaches.
So one other question, Danny, I see here is from Janice about, are you recommending, this APIs process for all the plans or just for the ones that CMS is asking? We certainly recommend all the plans, the payers that we are working with, they're doing it for all. It's almost hard for them to just do for one and not other. Then you're creating multiple processes internally.
And your providers, go back to your providers again. If you're a health plan, think about your providers. They look at you as care source, or they look at you as Regions, Blue Cross Blue Shield. They look at you as one entity. They don't look at you as payer commercial, payer Medicare, payer Medicaid. It is you're one entity. And so if they have a different process for different patients in your population, I said it a couple of times, I think this will save you money per authorization. MCG believes this will save you money on every authorization that comes through this workflow, as opposed to something else. And so we recommend you do it for everything.
Yeah. Go ahead. Any other questions here?
I'm looking, I had one more, but then I scrolled down in the chat and
let me surface this one. What are the pain points for coverage requirements discovery, the CRD, that we have seen? The way that CMS or the HL7 is envisioning is when provider is contemplating to order certain things to the patient, whether you're in schedule, whether you're really next to the patient, their goal is to have that answer come to the doctor or the provider in real time. So when you think about such an implementation on the provider side, providers need to enable certain events from the EMR, like when the provider is clicking, I'm going to think about a MRI for this patient, right? As soon as they click it, it should enable an event that can talk to payer and get the answer. So those technologies are not in place today. They have in place when you place an order to create a 278 and send it to the payer, but that is not a real-time process. So we are working with Epic and they are working on these things, and there are places where they're enabling these things so that you can access these things in real time. So we have used some alternative technologies right now where they have given us a manual button that you click it and access that information. But in probably later this year or next year, Epic will provide a real-time events to access that information.
Yeah, I think it's both. So I think, Janice, you asked, is it a technology issue or are there other things inhibiting it? I think Raj talked a little bit about the technology just now. I think there are also other things inhibiting it. So the readiness of payers to respond, if you think about everything is supposed to be a back end. There's supposed to be no human interaction on is an authorization required. But how many health plans do you know that can take an MPI, a first name, a last name, and a provider address, and give you one search result against their provider search services? That's what it would require to make it all back end. And so usually they're returning a list. Same thing for benefits. Is this service a covered benefit? Like, that's a lot of knowledge that's really encapsulated in human brains right now that's not necessarily discrete and discoverable by an API. And so those types of things, if you think about, there are technology issues for actually implementing the backend technology, but even if we implemented it, there are also some business pieces that are going to inhibit the success of it once it does get implemented.
Yeah, so one other question, one of the requirements for the patient access, provider access, and the payer is to include all the data, clinical and other, and share this information with provider and payer. So what exactly those data elements we are looking at, and what versions on the FHIR and US score and all that stuff. We are working on this very question, looking at the CMS proposal. I don't have a good answer for you. We have bundled everything when we implemented it, but in terms of providing this to patients, we haven't, our payers haven't implemented that yet. We are looking into some guidance on the rule, what exactly that means. So,
and I've seen a few. I've seen a few different questions pertaining to or comments, really, not questions. If you have comments, 2.5 years might not be enough to make this, all the medical policies ready for this. 2.5 years might not be enough time to implement this. Again, we're not, MCG is not CMS. So please do submit comments from your organization to CMS. The comment window is still open. And so please do submit those comments and get your voice on the record and heard from that. So that is
yeah, the other one is the extol to fire comments I've seen here. I totally understand. I mean, it is HIPAA is HIPAA, regulation is regulation. I don't think anybody can do anything. I hope probably in coming years they will relax that rule. Yeah. So Glenn raised the hand. Glenn.
Hi, Raj. Can you hear me?
Yeah.
Yeah, quick question. I'm still very new to the space, so just learning. So from a provider standpoint, is the expectation that as a single provider, I'm going to be interfacing with multiple payer smart and fire APIs? Or does a regulation put some responsibility on potentially clearinghouses to standardize, given they're somewhat of a gateway to multiple payers? Any thoughts on that and what you're seeing in that space?
Yeah. I can probably give a comment on this more than a CMS regulation. The requirement, if you implement the standards, so the providers, whatever the Smart and Fire app they're using, that Smart and Fire app is capable to talk to any number of payers, because we are all using the same standards to implement how to present a clinical documentation questionnaire and how to submit that information back to the payer. So from the standards perspective, if MCG has, our MCG Smart and Fire app, we will accept any payer's policies in addition to our own guidelines. So it's the same app that serves to multiple payers. So that's how we are thinking, and that's what the industry is thinking from the implementation perspective. If somebody has written a Smart and Fire app, it only works for certain questions, it doesn't work for other payers' questions, then it's a problem. But that's not how HL7 Da Vinci is thinking and how we have implemented. So we're almost at the time, Michael.
Yes, we are, Raj. And on behalf of WEDI, thank you so much to you and Danny for a fantastic presentation. Of course, timely. Just wanted to post on screen upcoming events from WEDI. As you can see, on February 28th, WEDI Member Position Advisory Session, Improving Prior Authorization Processes, NPRM, along with the Interoperability NPRM and the Attachments NPRM. Free for WEDI members. We welcome you to sign up. If you're not a WEDI member, please contact Bill Alder at BALLDER@wedi.org for more information on how you can be a part of these events. There is a cost if you're a non-member, but feel free to visit us at wedi.org for more information on not only prior authorization, but health equity, cybersecurity, and everything that affects the healthcare organization and industry. Thank you very much. Have a fantastic day.
Thank you all.